thank you, Dr. Hamza, and all the speakers in the opening session. Unfortunately, we are running a little late, so I would encourage you to ask questions individually outside after we finish the Crotti lecture. So we are now delighted to provide a fascinating presentation by this year's recipient of the Dr. Andre Crotti Award for Distinguished Service to the Profession of Surgery. I would like to invite Dr. Patricia Numann, who's a Lloyd S. Rogers Professor of Surgery Emerita at SUNY Health Sciences Center in Syracuse, to join us today as she presents Being Part of the Solution. Following her presentation, there will be ample time for discussion, and it's a very timely topic. Dr. Numann is an American legend. She is the founder of the Association of Women Surgeons, former president of the American College of Surgeons. She was the first woman chair of the American Board of Surgery, a position that she held from 1994 to 2002. She also co-founded the Association of Surgical Education and was the president in 1985. She has numerous awards and recognition, which too many to mention here, which includes, I would say, induction to the National Library of Medicine, Changing the Face of Medicine, local legend category, was inducted into the International Women Physician Hall of Fame, which I thought was pretty impressive. So we are really delighted to have her speak today as the Andre Crotti Award recipient. Thank you, Doctor. Let's see.
I didn't see them up there, but they were here when I was there. So they may be on desktop. If not, I have my stick. And it's just like I didn't see my slides up there on that little list of slides. So before I stood up here and tried to figure this out myself, I thought I had assistance. Great. Super. Thank you. President Nathan and President Parquet, thank you for this really incredible honor and privilege to present this Andre Crotti lecture. I wasn't aware of all of his contributions, but he was a remarkable surgeon. Born in 1873 in Buenos Aires of Swiss parents, he did his medical education in Lausanne and then came to Columbus, Ohio, where he helped Carrie Nelson, a philanthropist, develop and found the cancer clinic in Columbus, Ohio. And then in 1929, in the midst of the Depression, when he saw poor people not getting appropriate cancer care, he started a free clinic, which he worked with the rest of his life. He became the first president of the United States chapter of the International College of Surgeons, as well as one of the important founding members of the International College of Surgeons. And he created the motto that you have for all mankind, and certainly lived up to that, that promise the rest of his professional career, as your organization has continued to do over the years. I chose this topic because I was sort of raised to be useful. As a woman having ambitions that were not traditional, one had to be useful. If you were useful, people usually allowed you to stay in the room and to be involved in activities, and so I always felt that important. And I lived by this motto, which to my estimation really predates Eldridge Cleaver, who it is attributed to, that if you're not part of the solution, you're part of the problem. I have many people come to me with problems, but not a lot of people would come to me with solutions. And it became my rule as an administrator that I don't want to see you unless you have a suggested solution to the problem at hand. So what is the problem that I want to address today? And it's really the lack of access to surgical care for many people, particularly in low-income countries. And I would like to expand that to low-resource areas, because there are many places in the country that are really in high-income areas, but have really low resources. I was raised in rural New York, a place called Denver, New York. Nobody's ever heard of it, and you probably couldn't find it on a map, because it's not on most maps. But there we have today, we have no surgeons in the entire county that I was raised in. There's one critical access hospital, and if you want to deliver your child in a hospital or have renal dialysis, you have to travel 50 miles. So, and that's in New York State, which you would not consider a low income or necessarily a low resource area, but it has those areas. So what we're really aiming for is safe, accessible surgical care for all. And it requires a tremendous increase in the delivery of care, particularly in low and middle income countries, as well as recruitment of a workforce to deliver that care. And my particular interest is in requiring an increase in the number of women surgeons and the appropriate treatment of women surgeons. My interests have long been equity for women, both personally and professionally. When I applied for surgical residencies, my applications were returned saying we don't accept women and women shouldn't be surgeons. Of course, I listened to them and just went on and created my own opportunity and became a surgeon. It was such a problem to me, and I knew so few women, and I saw women being discouraged, that I actually started the Association of Women Surgeons, and it was always intended to be an international organization. It was never named the American Association of Women Surgeons, and we now have chapters throughout the world that have really been very highly successful in recruiting women to surgery and making sure that they have equal access professionally and that they have a good life personally. I sort of accidentally became president of the American College of Surgeons, but when any opportunity presents itself to myself, I always try to take advantage of it. And so as president, I decided that one of my initiatives was really going to be increasing the international representation in surgery in the American College of Surgeons and treating the international members of the college more equitably. I thought that they had really been given short shrift for most of their participation and weren't honored appropriately. I was invited to go to the Philippine College of Surgeons in Manila, and they actually called the college and asked them if I knew where Manila was, because nobody had ever come before. And I said I did know where it was and I was coming, and since then we've had a much different relationship with that college. Through that experience, I really became involved with COSEX's Women in Surgery Africa program. I met a young woman at one of the American College of Surgeons meetings who had started this Women in Surgery Africa program. She was supported a lot by the Royal College of Surgeons of Ireland, who supports COSEXA, which is the College of Surgeons of Eastern, Southern, and Central Africa. And they were having their first meeting of the Women Surgeons group, and she asked me if I would be keynote speaker in Blantyre, Malawi. I had no idea where Blantyre, Malawi was. I had no idea how to get there, but it seemed like a good thing to do. And so I agreed to go to Blantyre, Malawi, where I found that they had actually a large number of women surgeons, but they were very young. They were mostly not members of COSEXA because they couldn't afford to be. And where we are paid to train, they paid to train, and some of them were engaged in activities that I found horrifying to earn the money to pay for their surgical training. And this created an interest in us adopting them, and we now provide scholarships to those women so that they can get their fellowship and that they can belong to the organization. And it encouraged ACS Hope of the American College of Surgeons to give further support to them, give them grants for special education. So you can be part of a solution to a problem, and why should you be a part of that solution? Well, number one, because you're a member of the International College of Surgeons, you've said that you would. And the International College of Surgeons has an official relationship with the World Health Organization as a non-governmental organization, the only one that's purely dedicated to surgery. So you have this opportunity, and this is really the opportune time to to act, because although the World Health Organization was founded in 1948, prior to 2015, only 3% of its budget went to surgical care, with only a rudimentary surgical program called GSIC. But in May of 2015, the 68th World Health Assembly adopted Resolution WHA 6815, which really strengthened the emergency and essential surgical care and anesthesia program, and really determined that it should be an essential part of universal health coverage and an indispensable part of universal health coverage. So when GSIC was formed in 2005, it had very few members, it had very little money, it had one director who felt very lonely and isolated. But since that resolution, it's grown to have 2,300 members in over 140 countries. It has a real budget and it can do some real work. So this is the time for you to get involved in that. And around that same time, the Lancet Commission, even though it's a British journal that determines these commissions, they're wonderful. You should read them. There's so many. There's several done each year. But the one on global surgery was really particularly relevant to this group and to your activities. The Global Surgery 2030, which you've heard a little bit about, was provided evidence and solutions for achieving health, welfare, and economic development. It was chaired by John Mira, and the report was published in April of 2015. I went to the American debut of their recommendations. It was exciting, it was energizing, and it made you feel that you had to commit to do something to improve global surgical equity. Because in reality, the number of places in the world that have limited access to surgical care, way below that of what is expected or beneficial, is the majority of the world. It's the minority of the world that has real access, and we're fortunate that we live in a country that does have that kind of access, but it is limited. And this commission actually committed to thoroughly research the current situation, to make reasonable recommendations, and to do primary research to look at issues that had maybe not been looked at on a global basis. They developed clear and useful and concise metrics so that all the metrics would be the same. We've heard here today already how many countries have no metrics and places have no metrics, and the process of disease is poorly understood in their own country. They said that they would assure that there was research development in these countries, that it wouldn't just be what we think is best or what we kind of like to think about, that there would be actual research to look at what needed to be developed and what development made the most sense. That they would advocate for surgical care. They would get information that would inform and drive policy change. And one of the most useful things they did was they developed this template called the National Surgical Guide, which is available to the health ministries in every single country, anywhere in the world, that shows what is important, what you need to do, and a good guide on how to go about getting the information and deciding what is next best to do. Their primary research, you've heard some of it, that 5 billion people have no or limited access to surgical care, that we need to do at least 143 million more procedures per year to get up to what we think is important and necessary to reduce death and morbidity. And some of the things that are really even more devastating are 33 million people each year have catastrophic healthcare costs that put them into poverty. And if you look at those that are really endangered by it, it's another 43 million. And that without investment in surgical care, by 2030, the world will have lost $21 trillion. An amazing statistic. The other thing that was clear from the data that they did was that surgery is an indispensable part of healthcare, and the myth there that surgery is too costly and not very effective is just absolutely wrong. Surgery is cost effective, it can be provided meaningfully even in low resource areas. The International College of Surgeons and WHO, I think, therefore, at this particular time, have a really great opportunity. Your organization, for over 75 years, has had a unique relationship as an NGO with the WHO. You've conducted many, many missions, so you have a lot of experience. You have this SOTA online registry for volunteers that can be expanded and better utilized. And you have a committed workforce, and you have resources, and you are in a wonderful position to advocate for surgery as an essential part of healthcare. This year, the World Health Assembly meets in a little bit over a month. I know that you will be represented and present at that. You will be the only strictly surgical NGO, to my knowledge. And your international representative is a fellow named Nadia Kim from the United Kingdom. And he's a very energetic guy. I've spoken to him, but I didn't get the sense that there is a specific plan for what your ask is going to be from this organization or from the ICS in general. And I don't know what the specific plan is. I've talked to Dr. Parquet, and I know that there will be a delegation there, that there will be some interest, but I do think that this is a perfect time for you to capitalize on your status and to increase the access to surgical care and increase the commitment that the world has to providing access to all. So take advantage of that. In thinking about it and knowing a little bit about your organization, I think there are many things that could be asked. As I said, I don't think you should just be listing the problem. I think you should make some recommendations for potential solutions. And so one of the asks could be that you would be the coordinating body for humanitarian programs in surgery. You could develop a network of specialists for international consultations. You could build a pre-hospital network system, make recommendations for pre-hospital care. We've heard this excellent presentation that you can, if you can do it in India, you can do it anywhere as far as I'm concerned. I have been in many Indian streets where I worried about my life every second. So you can do these things. You can encourage best practices, both in the operating room, in trauma care, in many, many ways. You have the expertise for that. You have the knowledge to do that. You could look to help negotiate for durable equipment for facilities. If robots are the things to use, well, maybe you can negotiate to have robots in various regions that are strategically located so that they get the maximal utilization at a reduced cost. And look for perhaps some grant support, some support from the World Health Organization, from things that they can negotiate with World Bank and help you to get funding for that. You can also look at developing an international source of supplies so that you have a negotiated lower rate for your missions and for under or low-income countries. You can maintain a registry for various diseases, for trauma, for whatever you think is important. You can develop courses and research projects. Stages right now puts on a wonderful minimally invasive surgery course at every single COSEXA meeting. And I can't tell you how many people I've seen trained to do that. They've negotiated for very reliable equipment from low-cost suppliers, and the trainers are low-cost trainers. You can put together that program, and it can be done by an organization of this size, with this kind of commitment. You can, particularly through the World Health Assembly and World Health Organization, advocate for safe energy supply and a safe water supply for medical facilities. It's shocking to me how little solar power is used in much of this part of the world that has more solar energy than most of us who do use solar power. And it's reliable, it's safe, it's effective, it's generally low maintenance, and instead of having the lights go out when you're trying to do surgery in many of these remote places, you can have a reliable source. So these are some possible asks. You can also promulgate mission best practices, and I see there's a discussion as to whether missions should exist or shouldn't exist. Well, maybe missions should exist, but maybe missions shouldn't be done as always or as have been in the past. And you might need to think about recreating missions and how they work. But they certainly should have consistency, where you return regularly to a place until they have a sustainable program, and that the sustainability leaves the skills within the local people, not just scars on the local patients. We need to be open-minded as who can give that kind of care. One of our alumni from my medical school has a cataract program in Mongolia, And actually, he found that one of his surgical assistants, who was an uneducated woman, was doing such a great job that he had let her do more and more of the surgery, until the point that he let her do the whole operation. And now she runs one of the cataract surgery programs in Mongolia and does a large volume cataract surgery with literally no education but great training. So we don't have to necessarily look at board certified physicians who spent 10 years in postgraduate training and done a fellowship in everything from the top of the head to the bottom of the foot to give all surgical care. Other people can do it. We should really make sure that everybody always uses the surgical safety checklist. This has reduced death throughout the world greater than any one single thing, probably. We need to track postoperative mortality, and I think that should be defined like the ASAP does, the Alliance for Surgery and Anesthesia Practice, because again, we need precise data, we need consistent data, and we need data that is transferable from one place to another. So let's use the same metric and have it well defined. The other thing that became very obvious to me, particularly in talking to my African women, was that we really need to respect the privacy and the culture of the people in these low and middle income countries, and actually in every program that we participate in. They gave me, so many tales of people having pictures of them taken and sent all over the world that were very private, very personal, very degrading. That's not appropriate. Anybody, you shouldn't demean people just because they're impoverished or they're in a challenging situation. We should require that everybody have proper skills for the missions that they undertake. Again, stories from these the women surgeons in Africa that I got to know the best, of people coming to do operations that they never were allowed to do in the United States, that they never learned how to do, that they hadn't done before, that they would like to do a lot more of, and weren't, didn't have that capacity. That's just wrong. And again, you could even put together your own program for your own people who go on these missions, and many of them require that we learn skills that we don't know in these missions. And I actually even set a fracture in Laos, and I haven't set a fracture in a million years. But there was nobody else there. This poor little kid had a broken leg, and he didn't have the money to go to the hospital. He would have had to walk for 2 days to get there with his family. And so my guide said, well, can't you do anything for him? And I said, well, if they could make me a splint, I could set his leg. And so in like 5 minutes, they had whittled these pieces of bamboo, which fit perfectly. I got his mother's scarf, wrapped it around so he had some padding, had an ace bandage, which I always carry, put that on, and gave them a huge lecture about not taking it off, not letting him walk, and on and on. And then a few days later, they wanted me to go and stop and see him, and as I went back through town, and they said, I don't think so, I don't really know how this is going to turn out. But sure enough, he was sitting in his bed, absolutely happy, bandaged perfectly in place. And the guy kept telling everybody how I had really saved his life. In America, you don't think of setting a fracture as saving somebody's life. But in Laos, if you can't walk, you might just as well be dead, because you won't be able to be employed, you won't have a job, you won't get married, you won't have a family, because you're a cripple. And, isn't that sad that such a simple intervention can be done to save somebody that we don't do? The other thing that I think is important is for this as an organization to have a long-term strategic plan with regular assessments and updates. So you can look at your progress, you can see what you've done, and be proud of it and celebrate it, because I'm sure that you can do really many, many more great things than you've already done in the past. So possible next steps, make sure that you add documentation and follow-up to your missions. Add a research component to them. Develop in-country centers of excellence, so that you focus your activities in an area and develop a center of excellence there, bring specialists there. You can develop training programs there for all levels of providers, including nurse practitioners, nurses, midwives, a variety of things. You can look at having a grand program in one place rather than trying to solve the problems of the world. None of us can solve the problems of the world all alone. And so pick your program and where you want to develop it, and you can do very well. And it doesn't have to look like the American program or the British program. It can be unique, and it can fit the needs of the area and the resources of the area. and types of problems that they have in that area. So think about that. The other thing that I think came out of the Lancet Commission report is the necessity to have more academic output related to global surgery. And a review article in World Journal of Surgery in 2022 showed that the number of articles on global surgery actually from 2015 to 2022 went from 14 to 147, with an increase of 8% in trauma, 6% in OBGYN, but 80% of the authors were from high-income countries, and only 40% of the articles had, and 40% of the articles had no low or middle-income authors. Other studies have actually showed that there are more low and middle-income authors. And another thing that I think came out of that, and is a great addition, is the development of the Association for Academic Global Surgery. I know you have Patricia, who I worked with in that organization, who's very committed, who can tell you more about it. But again, it's an effort to unify academic surgeons around the world so that you have a network, that you have easy communication, that you have development of tools that can be used globally. And those things will make a tremendous difference in the long run and even in the short run. You have a publication, so you can make sure that you include local authors in your work. You support research development in these low and middle income countries. The Association for Academic Surgery, again, has a program at every COSEXA meeting teaching people how to do basic clinical research and teaching them a little bit more about data acquisition, et cetera. And you can actually, as I said, plan research activities around your missions. Make sure you include residents and medical students. They're really fabulous workers, got a lot of energy and enthusiasm, and they can help you gather data. You can publish this data. You can participate in global data acquisition. We've heard about vascular surgery and how critically important it is to have this cooperation of people so that you can get enough data to know whether something works or doesn't work, that you can actually get a better group of people to test new developments, et cetera. And you need to monitor progress and sustainability. Do these things continue to work? Do they live on after you? One of the terrible disappointments, if you've practiced as long as I have, is to watch the programs that we worked so hard to develop be dismantled by some idiot. Very, very challenging and very hard to keep your peace about. So another thing that you can do is you can help increase the workforce. As I said, develop non-empty health providers. There's certainly many, many people. We learned that through all of the wars. The medics in every single war have made tremendous contributions to the care of patients. And we need to really even consider new training paradigms. Do we have to train everybody to do everything, or can we train some people to do some things and have that be what they do the rest of their life? They would be willing to do that. They could probably be trained in a much shorter period of time, less expensively, and why not? Create good exchange programs. We've heard of one example. There should be many of those examples. The presence of a consistent specialist at certain sites. So pick a very successful site, look at that site, develop it, and make sure that it has the appropriate infrastructure. Vascular surgery, for example, you really need a lot of good equipment to do vascular surgery, state-of-the-art vascular surgery. And so instead of trying to spread it all out throughout the world, pick your site. Sri Lanka, I don't care where, but pick your site and develop that and have it as a model of excellence, an example of how you can do this and how one organization can do something so special and so important. And it may then become a center of excellence even for that country. And the other thing that I have to say is you need to aggressively train more women. It's not going to just happen. And it's really important because throughout the world now, currently, more than 50% of medical students are women. And in countries throughout the world where there is data, and I will tell you, having tried to get the data often, it's not available for most countries. But in Japan, only 6% of surgeons are women. And even in the United States and Canada, only 20% of surgeons are women. And if 50% of the medical students are women, and they choose surgery at such a low rate, we are in a self-fulfilling prophecy of the solution of the surgical profession. So you need to do that, and you need to actively recruit women. When you're taking people to the operating room, invite a woman. When you're going on these missions or to certain places, invite a woman. They're really nice in general, and they usually work hard, and so it's a good thing to do. And they get the fire. I can't tell you how often at AWS meetings I hear women say that, oh, they went to medical school, that surgery was the last thing that they were ever going to do, and they went to the OR and somebody let them cut a suture or touch the bowel or the heart. Oh my God, you know, and they were committed, that they thought that was the most fun that they'd ever had, and they were going to do it the rest of their life, no matter what anybody else said. So you need to do that, but you also need to support women's equality in general. For example, the new dean at the Aga Khan Medical School in Pakistan, a wonderful guy from Johns Hopkins, who has really aggressively increased the number of women in surgical training. But the one line in his articles that I read every time is, but most of them don't practice. Because the culture of the country and the ethic of the people, they don't want women to work. They want women to stay at home and fulfill the traditional role. So we need that. There are also still so many countries in the world where women are not educated. There's no mandatory education for women, even if there is for men. The World thing actually produces the gender equity report every other year. I read it religiously, and it talks about the disproportionate care for women and or the status of women in politics, healthcare, education, and social standing, or something's the fourth one. And it's really interesting. The United States doesn't do very well, and actually in the last decade we've gone from, I think, 28th to 37th, so we've fallen backwards rather than move forwards. So you need to know these things, and you need to address them, and you need to participate in changing them and making them better. And the other thing is, if you're going to recruit women to surgery, you should make sure that the environment is supportive, that they can be supported if they want to have children, they can be supported in the care of their children, and if they're not harassed or sexually abused. The reports of harassment in surgical residents, both men and women, is appalling to me. I knew that it went on when I was a surgical resident, but I thought we'd come a long way in that 60 years. And so I do think we have to address it, and we have to really speak out when we see it, and we have to prevent it in our own programs. And you can bring lasting care. You should look at new programs such as pre-hospital care. And you can help them improve sustainable technologies such as solar power, portable water, rapid sterilization. One of my friends was asked to do fistula repairs, and they wanted her to do 9 a day. And then they told her that the sterilization autoclave that they had took 4 hours to re-autoclave and re-sterilize the instruments. So she actually got somebody to donate one that would do it rapidly so she could do more cases. And even looking at 3D printers to print instruments, it may be cost effective in some of these places rather than depending on getting them imported when it's hard to do. And telemedicine, I mean, it is wonderful. And COVID has taught us that, and taught us that there's so much that we can do that we would have never anticipated. You could actually get follow-up care on these people. I never saw one single person in Africa that didn't have a cell phone. Not one. No matter where, no matter how poor, they could be naked and scrawny and look like they were going to die in the next 5 minutes, but they have their cell phone. And so you could follow up on the people you care for. You could do consultations that way. Our residents in the ER started doing consultations on burns in our rural areas very, very early using the cell phone. So it's easy to do these things. You could get specialist input to places that will never have specialists in a million years. You could probably eliminate every radiologist in all of Africa by having the films sent and reviewed like ours. Our night films are reviewed in Australia. I mean, so why couldn't you do it for areas that can't afford a radiologist or won't have one? And mentoring. It's so easy and so helpful to mentor these people because even though they live in different countries, they have different systems, they may have a different religion, etc. A lot of our basic values and what we do and what we need to do are really the same. My mentee, Matilda, is in Zimbabwe, and she's currently a fellow in burns and pediatric surgery. Not exactly a fellowship you find in America, but it's there, it's necessary, because they still cook with open flames, and so there are just enormous numbers of burns, particularly in little children. And so that's why she's combining that. And certainly we've heard a little bit about remote surgery. It is on the way. And I know Intuitive in particular, I know is very, very close to being able to do a lot of remote surgery. About these glasses were a wonderful idea. So those are things that you could offer. So my hope is that each of you will really make sure that you are informed about the needs in global surgery, that you'll assess what contribution you can make, particularly in low-resource areas, and it can be locally. Our medical students have a foot clinic with the Salvation Army. That saves a lot of unnecessary surgery for these people and loss of limbs because they didn't get foot care. And it's hard as a normal person to get a good podiatrist, etc. So these people are happy as clams. We get them socks and shoes, and they take care of their feet. I think you should make sure that any organization you belong to has a plan for global engagement and for contributions to low resource and low access people. Whether it's your hospital, your medical society, your medical school, other professional organizations, and you can push that and you can force that, just as I did with the American College of Surgeons. And you don't have to become president to do it. I got them to take notice of women as an assistant professor who was still pretty young. So you can do it. And I would ask that each of you support women and women surgeons and actively recruit them to surgery, because it will give them, number one, a wonderful life. I could have never had a better life than I've had as a surgeon. And so it's a good thing. So you say, well, what can I do in specific? Well, when you go home, you make a commitment to do something to improve access to surgical care. You could invite a medical student to join a mission. You can invite a medical student to come to a program on global surgical care. Help develop educational materials. If you can't go on a mission, help fund a mission, or recruit materials to be used on that mission, support a surgeon in a lower middle income country. The Deramides from Westchester, West Virginia, no, Princeton, West Virginia, endowed a scholarship at the American College of Surgeons that brings a Filipino surgeon to the American College of Surgeons every year, so that they can have that experience, they can mingle with other people, they can learn to do new things. And these are just father and son general surgeons in Princeton, West Virginia. So you can do things like that. You can help develop an exchange program. Participate actively in the International College of Surgeons committees. I can't tell you how many organizations I belong to where people actually go to a meeting, they talk about these wonderful things, and then they go home and they do it next year. That doesn't work. You have to have consistent activity. And the other thing, as one of the last speakers said, is you think outside the box. It doesn't have to be done the way it's been done in America. It doesn't have to be done the way it's been done for the last million years. You know, how well does that work? Look where we are. We got a lot of problems. And if we continue to do everything the same way, we're just going to continue to have those problems. So there are endless possibilities. And so I think that we can achieve global surgical equity because you can even eat an elephant if you do it one bite at a time. So I think your organization has to decide what that bite is going to be. So thank you very much.
Thank you for your wonderful speech. We have so many things that we want to do that we can get dispersed, and your conference for sure make us focus so we can get things accomplished. So thank you. I took a photograph of almost all your slides.
So Dr. Paquette, would you join us here? So Dr. Patricia Numann, in light of all your accomplishments as surgeon, scientist, educator, and a leader, the U.S. section has recommended you for honorary fellowship with the ICS World Body. Dr. Paquette, as the ICS World President, will officially confer this honorary fellowship upon you.
Wow, well, thank you. Very, very much.
By the power vested in me as the ICS World President, I officially confer upon you, Professor Patricia Numann, the title of Honorary Fellow. As a distinguished surgeon of international repute, your outstanding record has been evaluated by the Honors Committee of the International Crime Body and the International Executive Council, all of whom voted in favor and found you worthy of this high honor.
Well, thank you so much.
The certificate, and this is the, want to get that, if you want to picture someone. I think maybe we should stand in the front, down below.
I had my asthenia gravis, and so I'm a little wobbly, and I need a little support, more than I did, but I'm not quitting yet. And I'm almost the oldest person in the room.
That's not true. By young and not.
And it says I can say a few words, so I'm going to take it in. And the few words that I want to say is what I have said for most of my life. I'm nobody special. I'm not from anywhere special. I got a public education, and if I can do it, so can you. So just decide what you want to do.